I'm Jim Wiedrick. Every day I'm working to transform healthcare in Southeast BC, and one of my big ideas was this podcast where I get to engage smart people about topics that matter in healthcare in Southeast BC and what we can do to optimize patient care. Well, I'm really proud to say this is now episode number 13. And in honor of triskaidekaphobics everywhere, I made a deliberate decision not to invite a guest on this number of my podcast. Instead, you're stuck with me, and I thought I'd have a little bit of fun. It's a topic I really care about. It's the usages for CT, computerized tomographic scans, CT scans. And I thought I would put a nod to my youth and do a top 10 list, a David Letterman top 10 usages for CT scans list and why they're important and how we employ them in healthcare. So, quick little anecdote that's just a fun nod to a bygone moment in my life. I often watched Letterman in the early 90s, and I hung out in southern Ontario for the summer of 1996. Well, guess where David Letterman had his fictional home office where the top 10 list was generated? He had it in Wahoo, Nebraska. So, back in the day, Canada and the U.S. were on good terms, and I took off from the Toronto zone, headed back to Edmonton, but instead of doing the Trans-Canada Highway, which I'd already done on the way there, I went back and carved out a path that took me from Toronto to Denver and then back up to Edmonton, and along the way I made a point of stopping in the small town of Wahoo, Nebraska. Tell you what, couldn't find the home office anywhere. It was just fictional anyway. There was a big sign, there was a big nod, they were kind of fond of it. I bought a sub at the Subway and stopped at the gift store, and people didn't mind talking about the concept that David Letterman had made their town a little bit famous. But, it was a fun thing to do in my 20s, and I was a free spirit and just going on an adventure. So, story time with Jim is over. And let's start talking, going from number 10 up to number 1, a list that I've created of the top 10 usages for CT. So, I've had a chance to ponder. I've used the Internet of Things to help do a little bit of research, but even more important than that, I actually asked my colleagues. I asked my colleagues who are CT techs what they saw as the highest utilization rates for our scanner. So, as many of you know, I work at the Kootenay Lake Hospital in Nelson. We have a community CT scanner. It's definitely in need of replacement. I've been all over that point. The one in Trail at the Kootenay Boundary Regional Hospital needs to be replaced too. And more importantly, people in the East Kootenays need more than one. It's great that Cranbrook has one. They're kind of the referral center, but Mamma mia, we're living in 2025. It's beyond time that folks in Burnie and Invermere and Creston and these types of places have better access to CT scanners. Hey, I'm not forgetting you, Golden, either. All of those folks have been waiting for a long time, and I don't hear any meaningful news that there is actual progress getting them the kind of access to imaging that we need. When we think about small towns the size of Colville, Washington, 5,000 people, they got a CT scanner and an MRI, but we can only manage to do one of those for an entire sub-segment of the Interior Health Regional East Kootenay zone. Man, we need way more than that. We've got such a big geography, it's beyond time. All right, let's cue the drum roll. Here are the top 10 reasons why we use CT scanners in medicine in 2025 in southeastern British Columbia. And number 10, to look for infections and abscesses. Well, what am I talking about? I'm talking about big pus collections deep in soft tissue spaces that just don't belong. Here's a story for you. I was involved in the care of a teenager who initially we thought that he had mono, and he did test positive for mono, but he also tested positive for strep. Well, then 2 or 3 days later, he was getting really sick, and he had all sorts of pains and headaches and whatnot. Guess what? The guy ended up having a retropharyngeal abscess. That means way in the back. in behind his throat space, in behind his tonsil zones, up and tracking towards where the sinuses are. He was developing an enormous pus pocket, and it would have been super serious for him. Fortunately, his parents persisted. They came back a couple of times, even when at the first emerge visit didn't 100% figure out his problem. As the child got worse, he came back in. A CT scan showed the extent of the pus pocket. It needed surgery. He had to be intubated, ventilated, and flown to Kelowna, where an ear, nose, throat doctor got him a surgery. It's just a very noteworthy case that I remember from even my own journey of a time when, even though we could see something was very seriously wrong with this youngster and he needed something, that without a CT scan, you wouldn't understand the actual dynamic of it. It gives you that 3D reconstruction deep inside. It can show you the actual size and tissue infiltration of all the areas of the infections. Okie dokie. Number 9. So in cancer care these days, we have to monitor progression. We have to see how people are responding, say, to a chemotherapy regime. Well, that's monitoring. That's getting a CT scan every 6 months or some assorted interval and making sure that things are going okay. I mean, here's another example. Sometimes people are found to have pulmonary nodules. They look benign. They're probably okay. But can you be sure? Well, you need to do monitoring. So in 6 months' time, you got to look again. If it's doubled or tripled in size, we got to go after it and figure it out. But if it stayed the same, then you can feel confident that it's benign. That's monitoring. And that's number 9 on our list of usages for CT. Number 8, CT guided procedures. Okay, what are we talking about here? We're talking about interventional radiology procedures. So interventional radiology is when a X-ray doctor or radiologist is planning a procedure and they're needing to get needle access, maybe take a biopsy or do a drainage or insert a tube or a drain somewhere to facilitate a patient care. And they're using the CT scanner to make sure they get the 3D anatomy just right. That it's not a blind procedure. It's not ultrasound. Ultrasound's useful for some things in this space, but it's CT guided. And, a fully functional, well-rounded radiology department is going to have the ability to do CT guided procedures. And in this part of the world, those kind of things get done at the regional hospitals. Hey, we're on to number 7. Maybe we should get a celebrity out here to announce it and bring it in, but today you're just stuck with me. Number 7 is analyzing the chest for a variety of conditions that are kind of specific to that area. So one life-threatening condition that can crop up in the chest is pulmonary embolism, big blood clot in some of the blood vessels there. Well, if you're suspecting a pulmonary embolism, the gold standard these days is to do a CT PE scan. It's got X-ray dye. You use a protocol where you infuse the dye and then you take images over a timed period. You're looking for obstruction, for blood clots, for a CT pulmonary embolism scan. But along that sort of thinking, sometimes we're looking for aneurysms in the big blood vessel, the aorta that's just coming off the heart. Maybe you need to try to understand more the pathology, the actual disease characteristics behind a pleural effusion, or maybe you're looking for a pneumonia and you just didn't actually find it on the X-ray. That happens more commonly than people know. The X-rays are these 2D pictures, and sometimes they don't capture some more subtle things that CT, which is a 3D reconstruction, is going to actually capture. Hey, number 6, we're bringing on number 6, and I'm putting it down to something we call the trauma pan scan. What are we talking about here? Trauma pan scan. Well, pan means all, like throughout, and so it's common now that if someone's involved in, say, a car accident, maybe they've fallen off a roof, or maybe they had a quad, a 4x4 rollover or something like that, big trauma. It's affected many zones of their body. Of course, the emergency physician can do initial assessments over 1 or 2 minutes, and we do with our point of care ultrasound and just our clinical skills, our stethoscopes, these kind of things. But ultimately, the state of the art now is that if you're involved in a major wreck, you might have multiple deep injuries. If you're stable and you don't immediately have to go to the operating room, then many times the trauma team leaders are asking for trauma pan scans, and they're done in a certain protocol, and they give us tons of information so that the trauma teams can help sort of prioritize injury management and go through the whole list of things. That's number 6. And we're almost halfway there. We're down to number 5. Number 5, a big use for CT these days, evaluating fractures. So X-rays do a pretty good job of evaluating fractures. I've got an example from just even in the last month. A young lady was known to have had a extension injury. She fell and really jolted her elbow, got a lot of swelling. Initial X-ray didn't show anything, but that happens sometimes. Sometimes they're hidden from X-ray views just originally, and then in a week's time, something will show up. Well, in a week's time, she had only the subtlest of changes, but that's on the X-ray. And then when the orthopedic doctor suggests the CT and we do the whole 3D reconstruction, we can see little cracks here, an avulsion over there, something called comminution, which just means a whole bunch of breakup and whatnot, and it really shows the whole picture. So there's a reason why CT has gotten kind of the nickname of the diagnostic box now, because sometimes when things are a little bit in the dark, got to go there, and man, things that you didn't know were existing suddenly appear. People have ongoing clinical symptoms. You can't dismiss them. You can't say that they're normal or okay. Then from time to time, we've got to break out the CT scan to better evaluate the fractures, things like that. Boom, boom, we're on to number 4. What's number 4? Evaluation of stroke, hot stroke, or even cold stroke, if you like, transient ischemic attacks, the like. We're looking for changes, looking for phenomena to, number 1, rule out what's called a hemorrhagic stroke. That's a stroke that involves bleeding or a broken blood vessel, and compare and contrast that with maybe changes that are suggestive more of what would be called an ischemic stroke. Stroke these days, the treatment plans have changed. We have interventional things that people can go to Kelowna for. Some people over closer to the Alberta border might even be airlifted by Stars to the Calgary zone. At the end of the analysis, those folks need CT scans so they can guide treatment decisions, whether that be clot-busting drugs, if a person is meeting the criteria for that, or whether they need to get what are called thrombectomies. That's where they go in and do an interventional procedure to try and relieve the clot from the blood vessel in the major arteries that are serving the brain. So part of a hot stroke protocol now is what's called a CT angiogram. We're looking at all the brain tissue, looking to rule out bleeds, and then evaluating all the blood vessels in the neck and all the blood vessels in different parts of the brain. That is number 4. And as we transition over to number 3, still got 3 index cards here, the evaluation of abdominal pain. So sometimes people will broaden that out and even make it more like abdominal pelvic pain. But first and foremost, evaluating abdominal pain these days is known to be something where even the most seasoned, the most experienced clinician can get some of the signals wrong. And it's well understood that in a senior citizen, the textbook presentations for abdominal pain just sometimes aren't there. In other words, things often show up in an atypical fashion. So just because you think, oh, it kind of sounds like appendicitis, and then you're like, well, it could be, kind of fits from this point of view of the physical exam and this point of view of the lab tests. So many things can be hidden as in the adult's abdominal cavity that the surgeons just don't want to take consults or take people to the operating room if they don't have an actual CT scan to guide them to know who is a better candidate for an operation versus who isn't. I mean, back in the day, I think the year is 2012, when I did a bunch of assessments on people with abdominal pain during an overseas medical mission in Kenya. Well, we didn't have CT scanners in that rural mission hospital. If we couldn't solve the patient's abdominal pain problem, they had to undergo a laparotomy. That was an exploratory laparotomy. So that means you take a big excision in the tummy, you go in and you evaluate each organ hand by hand by hand by actually visualizing all the spaces. You're going to make a diagnosis that way. It's going to be pretty sensitive, but goodness gracious, if you say, hey, let's just have an exploratory laparotomy versus let's get a CT scan and get the same basic kind of information. I mean, the CT scan is not invasive and it's going to help really guide the therapy. So medicine's come a long way. We're not in the 1970s. We're not even in rural Africa that might be under-resourced. We're trying to run a sophisticated medical system now, and ultimately, if you're going to call a surgeon or think about what the exact cause of the abdominal pain and you haven't already figured it out through other ways, then CT is where people lean. Now we're on to number two. Number two, from my practice, I think that in the emergency department, the thing that gets ordered the most sometimes is a CT head looking for a brain bleed after a senior citizen who's on blood thinners has fallen. You know, this one hits close to home. I've had relatives who've had this problem, and it's a very real phenomena that many people are on blood thinners every day of their life, and they're on that for certain medical conditions that might predispose them to stroke. But people fall. Bad things happen to good people. And if you've had a trauma, maybe your level of consciousness has changed a little bit, or there's worry that you're developing an early brain bleed, the way to find out is a CT scan. Has to be done, and it's often done. It's become part of an emergency medicine algorithm. And last, but definitely not least, because this is used all the time. Whenever I asked anybody, hey, what do we use CT scans the most for? Immediately they knew that this was the answer. And the answer is diagnosing cancer. And man, isn't this sad? But such a high percentage of our population now is going to develop a cancer in their lifetime. And whether it's diagnosing the details of that cancer, finding out the extent of that cancer, staging the cancer. People have heard of the concept of staging. That's how many different zones in the body, the extent, some of the parameters and whatnot. And then finding out if the cancer has metastasized. CT scanners are used all the time in diagnosing and detecting cancers. It is an evolving thing, and as our scanners get better and better, that's where it's at. Kind of an indispensable tool. And so when I start thinking about the possibility of really old CT scanners breaking down or not having access to it, I mean, everything's going to get backlogged, and that affects a ton of people. We need the latest and best technology on this so we get the best information for doing these diagnoses. Hey, that was the top 10 list. I want to just take 1 minute before I wrap and just say, hey, there are definitely other uses for CT. Okay, so please understand this is a top 10 list. I mean, I can think of technology that is being used for what's called CT colonography, CT cardiac scans. We don't have access to that right now in our part of the world, but it's out there and it is definitely used in many corners of healthcare systems in the Western world. By no means is this list exhaustive. Check it out. Check around, ask friends, family, what they've had CT scans for. Think about people you know, and then ask yourself how valuable it is. I am constantly open and ready to talk with people about how we get more access to this kind of diagnostic technology. I'm a big advocate that our healthcare system is leaving us behind in the neighborhood of diagnostic imaging, and I want to do better and have more access. If you're with me, drop me a line. Email I often answer from is connect@jimwiedrick.ca. I'm so grateful you took the time to listen to this podcast, and we're going to be back in a couple of weeks with episode 14 with a live human and do an interview. Cheers.